I'll start. Okay. Yeah. Yeah. Hi, students. So this is the recall for the hematology. So I will start without any delay. So there were around 14-15 questions in hematology related also. So I think the major other specialties have been already been discussed or being discussed today in coming sessions. So I'll brush upon the hematology related or core hematology question. So one question to start with is acute myeloid leukemia prognostic factor. So I think this we have already discussed. AML is a very favorite topic of examiners. So prognostication, treatment, you get questions from all this. So this is a very common and age-old question. We also used to have the question at our times. So we know the prognostic factor for AML is basically cytogenetics or molecular based. And nowadays, more and more next generation sequencing based molecular markers are coming, which defines the risk. So why do we need to risk factor risk type AML? Because the treatment decision, whether to transplant or not, whether targetable drug therapy can be applied, is based on the presence of clonal leukemia clones, which has a particular marker, which also defines the prognosis. At the same time, it can give you an idea on the your next step of treatment. Say in a high risk AML, you know, it has to be transplant, allogenic stem cell transplanted has to be undertaken. Okay. Okay. So here the given option were translocation 821, NPM1, and SEPA complex karyotype. So it's a straightforward answer. Poor prognostic factor, we all know it's a complex karyotype. So this I have discussed in the QRP sessions. So we have the European Leukemia Net Prognostic Group. So this is 2017 on the left side, and the rightwards, this is a recently launched 2022 latest updation, where they have included much more molecular markers like we can see here: ECO, RUNX1, SF3B1, SRSF2, STAG2, and all. These are in addition to what we had in the 2017 ELN. Okay, so translocation 821, SEPA, NPM1, all these are good prognostic markers, whereas complex karyotype, meaning more than 3 chromosomal abnormalities, are an adverse prognostic risk. Okay, so next from AML we go to CLL. So CLL, it's a lymphocytic leukocytosis. So here they have given a total leukocyte count of 11.5 and a platelet count of 4.5 lakhs, a hemoglobin 11.5. And also clinically there was spleen and lymph nodes. Okay, so what is the RAI stage? So we all know CLL has two type of main staging: RAI staging, Binet staging. So RAI gives 1, 2, 3, 4, Binet ABC. So here there is this also we have discussed in the QRP sessions, and also I had framed a few questions also in the test questions. So RAI system, there is 0, 1, 2, 3, 4. So here they have given lymphocytosis. In addition, there is splenomegaly and hepatomegaly. Okay, so it's falls somewhere here. Okay, so when you get anemia less than 10, it goes into 3, and thrombocytopenia less than 1 lakh, less than 11 HB, and less than 1 lakh platelets is stage 3 and 4 respectively. And Binet is more or less the same. So you can get questions from either of these. Okay, so simple straightforward staging question. And you can also be asked how do you treat even earlier stages, intermediate risk, you can even observe even though the count is high. You treat once they develop anemia and thrombocytopenia. One thing you have to remember, this anemia part, it should not be an autoimmune hemolytic anemia. So autoimmune hemolytic anemia is a very fair common association with the CLLs and other lymphoproliferative disorder. If they have a autoimmune hemolytic anemia, that anemia is not taken as a part of this RAI staging. Okay, so now coming to the next question is, a patient, there's a given platelet count of 11.5 lakhs. So he or she was diagnosed as a essential thrombocytosis, which is myeloproliferative disorder, and he was started on hydroxyurea and ecospirin. Okay, so then he developed ecchymotic patches. Okay, So he got some bleeding manifestation. So what could be the probable reason? The option given were hydroxyurea related and dysfunctional platelets, hemophilia, acute bone Willebrand disease. So this is also a very straightforward question. So the patients who are on ET with excessive, so more than 1 lakh or sorry, more than 10 lakh platelet count, they are bound to develop something called a acute bone Willebrand disease. So the answer is D. So basically, the ET with extreme thrombocytosis, let's say if it is more than 15 lakhs, preferably this echospirin you have to hold, and ideally we should test for the Ricoff. Okay, so if risk setting cofactor assay, and so basically they tend to assess acute von Willebrand syndrome, right? So if it is less than those, we can guide your decisions regarding starting antiplatelets. Okay, that is aspirin at low dose. Okay, so ET also it is risk accordingly low risk, very low risk, intermediate, high, very high risk. Okay, this is based on whether you have a thrombosis or not, whether your age is above 60 years old. So accordingly, you can guide your treatment, whether you need just observation, or you need antiplatelets, or you need cytoreduction like hydroxyurea and acrylate, etc. Okay, so here the answer is acute von Willebrand disease. So coming to lymphoma, Hodgkin lymphoma, so which is not used. The exact question we discussed in the question paper or even in the discussion, QRP discussions. So here, what not used in Hodgkin? So daratumumab, straight away you know, daratumumab is a monoclonal antibody against anti-CD38, which is used in plasma cell disorder like myeloma. Okay, so here this is not used in Hodgkin. Rest, this bleomycin, vinblastine, doxorubicin, basically what they are asking is probably this doxorubicin. I'm not sure whether it is they meant dacarbazine. So options which I got from student is the doxorubicin, even though doxorubicin can be used in Hodgkin lymphoma. So ABVD is much very common regime used in Hodgkin. The exact question which we discussed in the QRP or questions sessions which I had. So bleomycin, vinblastine, dacarbazine, adriamycin. Okay. So basically, this is a standard regimen for this Hodgkin disease. Nowadays, they even use brentuximab vedotin, which is a monoclonal antibody against CD30. So probably they like to confuse you between brentuximab daratumumab, which is CD38, which is daratumumab. CD30 is brentuximab vedotin. So brentuximab vedotin AVD, which has been approved for stage 3-4 Hodgkin disease in young people. Okay, so here is a standard approach to stage 3-4 classic Hodgkin lymphoma. So preferred regimen ABVD. So 2 cycles later, you do a PET scan, which is called an interim staging, and you assess with this something called a Dewey score. We have another question on Dewey score as well. So this is the same picture which I discussed in the QRP sessions also. So after Dewey negative, 1 to 3 is deemed negative, 4 to 5 is positive. So negative, positive. So interim PET after 2 cycles of ABVD, if it is negative, you can omit bleomycin and give AVD for 4 cycles. If it is positive, that means you have to escalate. So escalated Biakov, which is a German regimen, 3 cycles and restage. Again, you if it is negative, complete the Biakov, or if it is positive, you may even have to do a biopsy, whether to confirm, again reconfirm the diagnosis, and then accordingly you can do. So brentuximab AVD is the standard of therapy nowadays. First line, it has been recognized as a first line regimen in young people. Okay. So now coming to a benign disorder like Crohn's disease, ileal resection was done. So which vitamin deficiency can be seen? So iron, folic acid, beta. So this basically tests your knowledge about whether this sorry. Okay. Hello. Sorry, I think there are some, yeah. I think the video is visible. Okay, sure. So I'll continue. So ileal resection done in Crohn's. So here they want to test about whether you know the mechanism of absorption, the biological how these vitamins and ions are absorbed. So if you have the basics, you get this answer. So here the problem is in the ileum. So, okay, so ileal this also the exact picture I have mentioned, and we have discussed in the QRP sessions about B12. So diet, the folic acid, polyglutamate, and food B12 combines with the intrinsic factor produced by the parietal cell, and they move down. The folic acids are taken up as methyl THFA, and intrinsic factor B12 complex moves down to ileum, and they bind to tubulin amnionless receptors, and then it is transferred across, binding with the transcobalamin through the portal blood. So here the ileum is resected. Okay, so major absorption of B12 happens in the ileum. So there we are looking at a vitamin B12 deficiency. So we also discussed that QRP about the B12 and folic acid, the major uptake, normal dietary uptake and all, which we should be knowing. Okay. So causes of B12 deficiency, again, pernicious anemia, immune-mediated autoimmune part of an autoimmune disorder where there is antibodies against the intrinsic factor, gastric diseases and surgery, partial gastrectomies, chronic gastritis. Hello?
Hello, sir.
Yeah.
Please mute, sir.
Sorry? Hello?
Sir.
Hello?
Your video is not visible. Yes.
Yeah, now it's okay? Hello? Okay. So, so probably there is some issue with the video feed. So I think now it's okay. Okay. So moving on, pancreatic diseases, intestinal diseases, ileal resection they have given, and parasitic infestations like bacterial overgrowth as in blind loop syndromes, etc. Okay, so reduced B12 absorption like cholestyramine, dietary factors like malnutrition, vegan food. Okay, inherited disorders like decreased expression and binding activity in, or affinity of receptors and proteins, etc. And some infections like HIV and nitric oxide, like anesthetists. You are exposed to nitrous oxide. Okay. So moving on, we have a question of viral infection after 2 months of allogenic BMT. Okay, so bone marrow transplantation is this topic. So, so we know that they're asking questions from it. So here they're asking infections post probably this might have been discussed by infectious disease faculty also. So here, basically, what happens is a transplant is basically something. It's like a rocket launch. I might have discussed in the QRP also. So here the countdown starts from -7. So this is the period of conditioning. Okay, conditioning meaning we give the chemotherapy. Say if it is leukemia, we give chemotherapy to kill the disease, whatever remnant, and also it will suppress the immunity. So two indications. So conditioning regimen is used to prime the individual so that it won't reject the graft. It will suppress all the immunity. At the same time, it will give the tumor kill also. Okay, so this is based on chemo or radiation. So chemo radiation combinations that are available with different kinds of protocols. Okay, so now on day 0 they infuse the stem cells, and following which plus days are basically you wait for the engraftment, which happens in the initial 2 to 3 weeks. And during that period, you get to face many infections like bacterial, fungal, viral, you name it, you have it. Okay, so usually this infections are usually complicated by GVHD. Either within the 100 days, it is acute GVHD, and later on it is chronic GVHD. And meanwhile, you get the immune reconstitution. Immune reconstitution meaning you get the proper configuration of your T cells and B cells. So this immune reconstitution occurs in the say first 100 to say 3 to 6 months. Okay, so during this phase you are facing many lot of infections. In initial phases, once the graft is not have not come up, like the engraftment period, you get gram negative positive bacteria, then fungal infections, Okay, and then later on, moving on, you get CMV infection, PCP, and many viruses comes up. EBV comes later on, post-transplant lymphoproliferative disorders and all. It's a long-term and complication. So probably here, the question probably they meant by CMV. Okay, so CMV is reactivated. So especially if it is haplotransplant and all, the CMV reactivation rates are more. Okay. So next is anemia. So this is a very time tested question which stand still relevant. Okay, right. Some issue with the video feeds. I don't know. Probably it is not. Okay, so anemia with low MCV, raised TIBC, and ferritin 59. Okay, so possible diagnosis. So here so these are the DDs of a microcytic anemias. Okay, microcytic hypochromic anemia. So here probably the best fit would be an iron deficiency anemia. Okay, we have discussed this chart in the QRP sessions. So this is chart taken from the Hofbrand. So there are the 4 main DDs of a microcytic hypochromic anemia: iron deficiency, classic, chronic inflammation, that is anemia of chronic disease, thalassemia trait, and sideroblastic anemia. Okay, so this is basically this iron levels and TIBC. They are the opposite. Like if the iron is severely reduced, TIBC is raised. That is the typical of iron deficiency anemia. Whereas here in inflammation, both are reduced with the elevated ferritin. Okay, this is a classical difference between iron deficiency and chronic inflammation. Thalassemia, all these parameters are normal. Sideroblastic anemia, the serum iron and ferritin is normal, raised, sorry, and TIBC is normal. Okay, so this chart you have to be very thorough. Whenever, even if you are going for an INASS, this has to be very thorough. So next up is anticoagulation. Okay, anticoagulation again. I think there is some serious issue with the video. Okay. So anticoagulation of choice in patients undergoing angiography, angioplasty in a patient having history of heparin-induced thrombocytopenia. So this is basically very tricky questions. I think the cardiology faculty might have also discussed, it seems. So this is basically specifically they are asking for a choice of anticoagulation in patients who are undergoing angiography, angioplasty. So there is something different from the routine hit management, right? So I have to. Sorry. So anticoagulation of choice. So this here the question answer is bivalvuranine. So basically, this fondaparinux and bivalvuranine is a close call between these two. The problem is in angiography, angioplasty, where you have to place a stent. The stent thrombosis is more with the when you use fondaparinux. There are RCT trials proving that. So here the best bet would be bivalvuranine. Probably this is a complex or close call question. So this is the answer is bivalvuranine. So here we have to know about HIT, the 4 T's of heparin-induced thrombocytopenia, degree of thrombocytopenia, timing, thrombosis, and other causes ruled out. This has been discussed in the QRP. So the commonest drugs used for the management is direct thrombin inhibitors and this factor 10A inhibitors, right? So lepidolin, bivalvuranine, ergotamine, dabigatran. Okay, these are the doses has been, you should know, be knowing the doses also. And coming to indirect factor 10A inhibitors, one is darapyridine, fondaparinux. Here, since there is a risk of stent thrombosis, the answer would be bivalvuranine over fondaparinux. And coming to the Darby-Poitin side effect. Darby-Poitin side effect. So we all know Darby-Poitin is a recombinant erythropoietin. Okay, it's like longer acting. Okay, so options I could only get thrombosis versus bleeding. So here the thrombosis is the answer. Okay. Here I give a chart of commonest toxicities and their incidence. So here we can clearly see thrombosis is mentioned. Especially the thrombosis is high when the hemoglobin rise due to the Darby-Poitin is more than 11 or 12 gram. Okay, so usually what we do is you should achieve a hemoglobin level at least around 10, but not more than 12 or 11. So thrombotic risk increases with the rise in hemoglobin as well. Okay, so there is a pictorial question. Identify. So this is a random picture which I could get from the internet. So most people said it's a Reed Steinberg cell, like the classic bilobe nucleus with the classical owl-eye appearance. So they can ask classical like APML or promyelocytic leukemia, faggot cells, or the Trider cell classical offer. So that pictures you should be, or even they can give you pictures of like HP electrophoresis, where you need to identify the graph of the thalassemia, heterozygous, homozygous, or compound heterozygous with other hemoglobinopathies, etc. So you should be aware of that. Okay. So which score is used to look for the effect of chemo? This question I have already discussed earlier, that basically this is the PET score, Deauville score. Okay. Here the answer is B. So the score that already I have mentioned, PET scan is basically a modality which is used to assess the response of malignant, especially in my hematology, lymphoma, myeloma also. You can this PET scan is coming more and more, lytic lesions and extramedullary plasmacytomas, etc., and assessment of lymphomas basically. So Hodgkin, non-Hodgkin lymphoma, what PET scan does is we inject a radio tracer, that is the 18-fluoro-FDG. Okay, so this is attached to a glucose, right? So what cells take up glucose more? It's the malignant cells, or wherever you have an increased activity. So even if it is an infection also, the PET uptake will be more. But there is a range of PET uptake which is expressed in a standardized uptake value or SUV value. Okay, so this is basically this Deauville score is basically used to assess, say, the earlier case, Hodgkin lymphoma. We assess the interim PET after 2 cycles, and you score it. So 1 to 3 is deemed negative, 4 and 5, and X is new lesions. Okay, these are positives. Okay, so this basically they compare the SUV values and uptake of the mediastinum, liver, etc. Okay, whether new lesions are coming up or not. So no uptake is 1, uptake less than that of the normal mediastinal pool is 2, uptake more than the mediastinum but less than liver is 3. Okay, moderately higher than liver, if it is then it is 4. Okay, higher than liver it is 5. New areas it is X. Okay, so accordingly you change your therapy. So this is the same picture. So we have 2 related questions. Once they asked ABVD, then this PET. All these were detailedly discussed in the QRP session. Exact the same chart and flowchart has been this same pictures I have described. So possibly those who have gone through it might have able to easily mark the correct answer. So again, AML. So AML, the best prognosis with treatment. So this they have FAB classification is given. That is the M3 numbering is basically the FAB classification. So nowadays the classification is basically WHO based. So recurrent abnormal AML with recurrent genetic abnormalities like that. Okay. So APML. So here the best prognosis on treatment probably what, because for me except M3 all are the same. Okay. So except M3, all the other AMLs are treated with the standard induction chemotherapy like 7+3, FLAG, whatever. But M3 is different. Okay. So M3, what is M3? Basically, it is an arrest at the promyelocytic leukemia. There is a translocation between PML and RARA, which is the 15 and 17 chromosome, and there is an arrest at the promyelocyte state. So PML fused with RARA, which is a PML is apoptosis transcription of HSC, that is hematopoietic stem cell. RARA is basically the retinoic acid receptor. So they physiological combined with physiological retinoids, co-acetylation happens, which eventually leads to transcription differentiation. What happens in fusion is the inhibition of the transcription differentiation and apoptosis, which turn it into a leukemia. Okay, so the morphologically there are 2 variants: classic variant, hypergranular, which is the commonest, microgranular variant. Molecular, the standard is 1517. There are variants of 1517. In even for translocation, 1517 variants include the cluster breakpoint as per the breakpoint where it has fused. BCR1 is more common and BCR3, BCR2 is the least common. Okay, and variant translocations are available, other transcription other than PML-RARA is basically with NPM, Pneuma. Again, I think video is some issue with the video. Okay. So NPM, Pneuma, PLZF, etc. So this PML-RARA is the most common, 95%. PLZF is less than 5%, Pneuma less than 1. So basically, why there are different variants transcripts also you should be knowing, because there are transcripts which are not responding to retinoic acid therapy like PLZF. Okay. So smear, you see hyperleukocytosis, M3 variant. So this buttock-shaped cells, apple core, or rods, faggot cell, all this can be asked as that Reed Steinberg, like pictorial questions can be asked. Bone marrow is confirmatory, and you do flow cytometry, you get a teardrop pattern. HLA, DR, CD34 negative is the classical of APML. Other myeloid markers, 1333 MPO, CD117, etc. are positive. Okay, and karyotyping, fish PC4 confirmatory, translocation 1570. Okay, these are the buttock shaped cells. Here you get the orods and stacks of these orods. They're called the faggot cells. Okay, so here is the 1517 translocation in karyotyping. This is the karyotyping G banding technique. This one, and here it is a fish. You give the props as a PML-RARA fusion props. Okay, now again. G6PD. This also I have discussed. So all of those questions are discussed in the QRP session, which I'm glad to at least touch upon all these topics. They're very easy for those who might have already gone through the QRPs and questions. So here the drug with definite risk of hemolysis. So G6PD, we all know there is a Harrison. There is a chart showing. Sorry. Okay, so there is a gradient chart where definite, probable, like that. So G6PD, this chart, exact chart I have discussed in the QRP session. Again, there is a here the options are quinine, sulfasalazine, nitrofurantoin, and chloroquine. So chloroquine, sulfasalazine, and what we have is I think nitrofurantoin here, and chloroquine. Sorry. Quinine. Okay, so here the answer would be nitrofurantoin. So definite is a Harrison chart. So definite risk, possible risk, doubtful. So other options are quinine, chloroquine, sulfasalazine in the possible and doubtful risk. So definitely nitrofurantoin is the answer here. So one last question is asymptomatic female with the cyanosis blue-eyed, possible cause. So this is excess nitrates in the water. That is possible cause is methemoglobinemia. So very asymptomatic female, when you check the saturation, it is say 88%, and you get a cyanosed and blue tongue. So probable answer would be methemoglobinemia. Similar exact question which we have discussed in the QRP is this. This is a symptomatic kid, a 12-year-old girl with emergency dyspnea, which is discussed in our QRP session, dyspnea on exertion, as a dental extraction with parailoquine. Okay, and she was mildly cyanotic, saturation 80%. Otherwise, ABG was normal. He was treated with the IVS. So one clue is that ABG with coaximetry showed a methemoglobin. So she was treated with the IV ascorbic acid. So treatment for methemoglobinemia is IV methylene blue or IV ascorbic acid. So we also used to get a lot of this methemoglobinemia, which is very beautifully treated with IV ascorbic acid. Say if you give IV 1 gram 8 hourly, so next day the methemoglobin will drop and it will be asymptomatic. Okay, so this milder, so it's a condition. What is methemoglobinemia? It is basically there is an increased quantity of hemoglobin in which iron is oxidized to ferric form, and it is useless basically because it is a oxidized form. Okay, so most common cause basically the clue is there is ingestion or exposure to other oxidizing agent. So there is a long list of oxidizing class of drugs which can all cause this methemoglobinemia, phenacetin, phenacetin, dapsone. So the case which we discussed in QRP, they basically had an injection of this prilocaine. So local anesthetics, can precipitate. And here the other question which I've asked in our NEET SS was nitrate salts, excess nitrate salt, which can cause methemoglobinemia. So less than 10, it is just a gray skin, which has only cosmetic relevance. But as the percentage increases, the symptoms will change. So up to 20% can manifest as cyanosis, then later on dyspnea, dizziness, palpitation, confusion. 50 to 70 is dangerously high. You can have seizures, arrhythmias, metabolic acidosis. More than 70 is mortality. Okay, so thank you. With that, I think we stop with our QRP. So I think the QRP sessions were covered almost all the questions of this thing. So I would suggest students to go through it so that this can help you in INA, upcoming INA access also. Okay, so I think that's it. Thank you so much, and all the best for all the students. Thank you.